The call of nature, fluid strategy in traumatic brain injury. I have no competing interests. Dear colleagues, it's very simple. In the physiopathogens, you have primary injury, which is direct injury to the parenchyma, causing shearing and compression, and you have secondary injury, which is a complex process and leads to edema. Now, if you go to the Webster's Dictionary, edema is an abnormal collection of watery fluid in a bodile tissue or cavity. And we are all trained by the fact there is something which is like the Monroe-Kelly principle. The brain is just the brain, and the more fluid you put in there, the higher the intracranial pressure raises. The cranium is a fixed fold, and brain parenchyma, that's very interesting, is 80% water, which means that brain volume is responsive to changes in water content. So we were all trained to augment perfusion pressure and to lower ICP. So from that point of view, if your brain is pressure, you should keep it dry. But it's not that simple. The second quote is that you have something like a blood-brain barrier, and that you have very difficult physical properties which regulate that by formulas which you probably don't know anymore. In the Lund concept, which is totally opposite to what we are usually trained for, there is a heterogeneous disruption of the protective blood-brain barrier, and the Starling equation, which I just showed you in the previous slide, is used. And in the Lund hypothesis, where all Americans say it only works at Lund, they say that you have to reduce arterial and venous intravascular pressure and to supplement oncotic pressure with albumin. A very interesting finding only recently published is the fact that if you give an osmotically active agent, your osmolarity into the cerebrospinal fluid also increases, which means that in a patient with traumatic brain injury, that blood-brain barrier, which was already stated 30 years ago, is not working very perfectly. But what do we encounter in our patients with traumatic brain injury? The first one is we encounter many periods of hypotension. It occurs in 73% during the ICU stay of somebody with traumatic brain injury. It's one of the most independent predictors of severe outcome, doubling the mortality if it occurs both in frequency and in duration. It's the most amenable to prevention, and intravascular volume depletion usually occurs not related to the traumatic brain injury itself, but some fluid or blood loss at another site. And hypovolemia and hyperosmolarity worsen brain edema. The second thing what happens in our patients, and which makes it so difficult, is that all kinds of electrolyte disturbances occur, such as hyponatremia. And don't let me explain you this graph, because it will take us hours, what all regulates this difficult interplay. The third thing, which is so important and happens, and which frequently not taken into account, is hypoalbuminemia. Many of our patients with traumatic brain injury have a low albumin serum level. And you know all the causes of hypoalbuminemia in critical illness. It's not different in the patients with traumatic brain injury. And there have been a few studies which clearly show that the low albumin level in patients with traumatic brain injury also determines your outcome. Actually, it is one of an independent measure. It increased the severity of stroke. Actually, it causes a very poor Glasgow outcome scale if you have a low albumin during the course in your ICU with traumatic brain injury, and so on. And fourth, and we all know that simple regulation of fluids is not frequently taken into account, because the autoregulation, the perfusion related to blood pressure, is not that simple in patients with traumatic brain injury. I was asked to answer the call of nature in traumatic brain injury. Now, if you go again to Webster's Dictionary, the call in nature is to pass liquid from the body. So it's very simple if you have somebody with a traumatic brain injury. You should keep the brain dry. Probably forget it. in all guidelines is stated that you should have at least some aggressive fluid administration, guided by central venous pressure or by Swan-Ganz, if you still do that. We all know from our experience that excessive and inappropriate fluid administration causes fluid overload and ARDS. But there have been known randomized trials if you really have to keep the brain really dry or give a lot of fluid. So we cannot answer this question at this moment. The second question is, what should we use in patients with traumatic brain injury? Usually in all guidelines, crystalloid-based fluid strategies are favored. But the evidence in brain injury is very limited, and it's usually a pragmatic approach to resuscitation. This probably struck us the most. Based on the SAFE study, first published in 2004, comparing albumin and saline in general fluid resuscitation in the ICU, where critically ill patients were randomized to getting both albumin and saline for fluid resuscitation, and seen what happened at outcome, for instance, at 28 days, and other outcome parameters, it was shown that there was no difference in the general ICU population. And what do you do then when you see no difference? You do a post hoc analysis, because then eventually you might find things interesting. So this was the conclusion from the trial. No change actually between saline and albumin. So at 28 days, look very carefully, 4% of albumin compared with saline. So then they went on to the post hoc analysis in patients with traumatic brain injury. And they took out 460 patients with traumatic brain injury out of this larger randomized trial and tried to find out the same conclusion as previously stated. And this is what you do, 250 randomized to albumin and 260 to saline. The characteristics of the patients were very comparable. The physiological effects were very comparable, but the outcome was completely different. The ones treated with albumin had a very high mortality at 28 days, or higher mortality at 28 days, 6 months, 12 months, or 24 months. So the conclusion of the authors was, related to the Kaplan-Meier estimates, that your probability of survival declines if you treat your patients with albumin instead of normal saline in this post hoc analysis as stated. And this forced two guidelines. Consensus statement on colloid volume therapy as interpreted by the respective ACM task force actually state that no colloids should be used in patients with head injury. But Houston, we have a problem. Because in this SAFE trial, and also in this sub-analysis of patients with traumatic brain injury, albumin 4% was used. And I will discuss this later on. Many other smaller studies have shown some beneficial effect of the administration of albumin in traumatic brain injury. And although most were not randomized and well controlled, they show us something. Somewhat lower mortality. The other study we are waiting for is an acute stroke, where albumin is used, and the interim analysis shows eventually some beneficial effect. But at least those dramatic changes I've seen in the SAFE trial have not been reported in the other ones. And in a recent, very limited trial in 92 patients and with historical controls, I completely agree, taking the Lund hypothesis and using albumin, the combination of 4 and 20% of albumin actually showed no higher mortality according to historical controls. Albumin, 4 and 20%. 3. Should we still be allowed to use hypotonic solution? The brain needs glucose as the only energy formulation, actually. The only organ which exclusively uses glucose for its energy is actually the brain, even it may be deleterious. And of course, you see the large amount of differentiation and sodium chloride levels among different solutions we use. And then totally hip is hypertonic or hyperosmolar solutions. We use mannitol to cause ICP decrease to obtain a certain osmolarity, but we have to compensate usually by adequate fluid replacement. And we use hypertonic saline by increasing salt. You know the differences between mannitol and hypertonic saline. And it's very funny. If you ask our ICU physicians why we use mannitol and hypertonic saline, it's actually not based on many randomized trials. We don't have them. It's because it's our habit, because we believe that there is less pulmonary edema if we do mannitol. It might be more effective, or there is less risk of hemolysis. In a recent, actually, paper reviewing all the data, there is a little bit, just give me 2 minutes, favoring sodium. But we have not listened to the nature, because what we have forgotten is that in the SAFE trial, albumin directed to hybomemic resuscitation endpoints was used, but not maintaining albumin throughout the true course. We've just given it, and we've not seen over the whole period time. And we have forgotten to calculate osmolarity. Look what I wanted to make the point between 4% and 20%. This beautiful paper of Aken, a very short paper in the Acta Anesthesiologica, in the current opinion anesthesiology. If you calculate even the albumin 4% to the theoretical osmolarity, it's lower. It's actually probably not an hyperosmolaric, but even an hypoosmolaric solution. I'm going further on, because otherwise I'm going to be thrown out of the thing. So I'm a little bit confused. On the one hand, we want to keep the brain dry. On the other hand, we want particles to pass and to augment perfusion. On the other hand, we want to exchange fluids. The conclusion is, large amounts of fluids can be used in traumatic brain injury. There have been no randomized trials. Colloids should be used with caution, but should not be thrown away at this moment. Avoid hypotonic solutions, because there's fluid exchange over the brain. With albumin, the discussion is continuing, because in all these studies we use different percentages, and hypertonic solutions can be used. And then at this moment, we end actually with the call of nature. And I'm very glad not to be thrown out of my talk. Thank you very much.